So, for our last lecture of the immune system, we are going to talk about how the immune system develops, and we're going to talk about disorders of the immune system. So, we're going to start with development first. So, lymph nodes develop around week 5 in a pregnancy, and they are known as lymph sacs. And mother and fetus actually share antibodies during pregnancy, but the infant begins to lose those antibodies in the weeks and months following birth. However, breastfeeding can in fact provide antibodies to the infant, but those antibodies are only temporary. They will eventually degrade, and the infant's immune system won't be mature enough to develop their own antibodies until they're 2 to 3 months old. So once we have a functioning immune system, once we are 2 to 3 months old, how do we get our immune system? We have an active pathway where we are responding to infectious agents, to antigens, and producing antibodies like we talked about in our second video. Those are what we would consider naturally acquired. So that's when you have an infection, you come in contact with the pathogen, and you learn to make antibodies from that infection. We can also do this exact same procedure artificially through the use of a vaccine. Vaccines are either dead or attenuated pathogens, which means we've taken the parts that would be used as antigens and just inject those. So either we've taken away the DNA out of the infective agent, the pathogen, or we're just using the parts. We also have passive methods of acquiring immunity. These would be things like antibodies passed from mother to fetus or in breast milk, like we just discussed. But we also have artificially ways of getting passive immunity, and that's where we use antibodies from donors and inject those into patients. So you have the antibodies produced by a different individual, you isolate those, and then utilize them for a sick patient. And so this is how we develop our B and T cells. So as we talked about in our last discussion, we talked about how the bone marrow is the origin site for both B and T lymphocytes, or B and T cells, and then it's where they mature that determines whether they're going to be a B cell or a T cell. T cells mature in the thymus, B cells mature in the bone marrow, hence their names, and it's where they get immunocompetence, which is where they can tell the difference between a pathogen and your own human body. Then these get moved to the secondary lymphoid organs, so they're going to move to things like lymph nodes, or they're going to circulate in the blood, or they're going to move to the spleen once they go through the maturation process. And then, just like we talked about, they're looking for antigens to encounter. So when they encounter a new pathogen antigen, that's when they'll become activated and learn how to make the antibodies needed to fight off that infection. And proliferation and differentiation, that final stage is just multiplying or going through mitosis over and over again until they have enough antibodies to completely overwhelm the pathogen. So now we're going to talk about some disorders of the immune system, starting with bubonic plague. Bubonic plague gets its name from buboes, which are inflamed, swollen lymph nodes. These in bubonic plague can often become necrotic, which means the tissues actually die and become black, and that is towards the end stages of the illness's progression, but it's incredibly painful as they become overwhelmed and swollen. Another disorder of the lymphatic system is when the lymph nodes become secondary cancer sites. Remember, we talked about some white blood cells that specialize in neutralizing or killing off cancer cells. And cancer cells, when they metastasize, actually begin to move through the body. And they end up in the lymphatic system just like a lot of fluid does. And because they slow down the flow of lymph in the lymph nodes, they can actually take root and start developing tumors inside the lymph nodes. And that is incredibly dangerous because the lymphatic system obviously has that direct line to the heart, and then obviously that leads to anywhere in the body. Splenectomy. Remember, this is where we talked about the surgical removal of the spleen. Usually this is due to the spleen rupturing because it has been inflamed due to infection. This was once a standard treatment to prevent hemorrhage and shock, but now we know that the spleen can actually repair itself and doesn't necessarily need to be fully removed. However, if the spleen is removed, the liver and bone marrow can take over the functions of the spleen for the most part. Lymphangitis. This is where we have inflammation of the lymphatic vessels, and they actually become so enlarged that they become visible underneath the skin as they become very swollen. Lymphedema. This is where we have localized edema. This is where basically the lymph vessels are no longer draining. So edema is where you have just retaining of fluid in specific areas. And this is usually because the lymphatic vessels are blocked either by a plaque or infection, or sometimes it's a tumor that are blocking the lymphatic vessels from allowing that fluid to move as it's supposed to. Usually, if the blockage is removed, the edema will drain, and usually the lymphatic vessels will actually enlarge to accommodate that. So you are probably familiar with blood types. Blood types have a huge impact on the immune system because red blood cells don't carry MHC class 1s. They have their own set of proteins that identify them as part of the one's own body, I should say. So this is a quick chart about who can donate to whom. And just remember that O is the universal blood donor. It does not have any proteins on its surface, so it can donate to any other individual. And MHC class 1s are a way for us to identify our own organs, and this is one of the things that is really important for understanding like organ rejection when we have organ transplants, is when a patient has an organ transplant, we need to make sure that the organ is going to be accepted as easily as possible. So checking to make sure that as many markers that could match are matching. And even when we have a really good match on organs, it is still important to put the patient on immune suppressants. Immunosuppressants are a set of drugs that prevent the T cells from checking MHC class 1s. So they prevent organ rejection because they prevent the T cells from attacking that donated organ. An individual who is an organ recipient has to go on immune suppressants for the rest of their life in order to prevent organ rejection at any point in time. The downside is that it suppresses the entire immune system. It means that the T cells are not working effectively. So any kind of infection is incredibly dangerous because your immune system cannot fight it off because you're suppressing the action of the T cells. So some immune deficiencies. So first we have severe combined immunodeficiency syndrome. This is SCID. This is where we have an enzyme that allows for some metabolites, which are the leftovers of a certain metabolic reaction, to accumulate in the blood, and that destroys T cells. And this is actually fatal if left untreated. The most common treatment is bone marrow transplants. We also have Hodgkin's disease. Hodgkin's is another type of immune deficiency. It is also incredibly dangerous, and its big identifier is that it actually doesn't start displaying symptoms until much later in life, until about the late 40s. And it can be incredibly difficult to treat. And then we have human immunodeficiency virus. This is actually a virus that the host cell of choice is the T cells. So it attacks the immune system directly. And if the disease progresses past a certain stage, you have acquired immunodeficiency syndrome, which is AIDS. We now have a treatment for HIV that prevents it from progressing into AIDS, depending on the type of HIV that you have. There are several different versions of HIV. And with the certain type that we can treat, we have actually had several people who have been treated into remission, which means we have no detectable levels of virus in their bloodstream when we check it. So pretty great advancement in the treatment of HIV. Autoimmunity. So autoimmune diseases are where the body produces antibodies that attack itself. So this is where we have T cells that are actively trying to destroy body tissues. We have several examples. We have rheumatoid arthritis, where the T cells are attacking the actual joints, the cartilage on the surface of bones. We have myasthenia gravis, which impairs nerve muscle connections. So this is those skeletal synapses. We have multiple sclerosis, which destroys white matter's myelin sheaths. We have Graves' disease, which causes hyperthyroidism. We have type 1 diabetes mellitus, which destroys the pancreas. We have systemic lupus, which affects multiple different organs. And then glomerulone epheteris damages the kidneys. And then the only other treatment for autoimmune diseases is immune suppressants, which, as we talked about when we talked about organ donation just now, it suppresses the entire immune system. And then we have kind of the lighter aspect of autoimmune. We have hypersensitivities. We have two types. We have immediate and we have delayed. And those two types are distinguished by the time it takes for the reaction to occur and whether it's antibody driven or T cells are actually involved. If we have antibodies that are causing it, it's called an immediate and subacute hypersensitivities. If we have T cells that are the cause of the hypersensitivity, that's where we see the delayed hypersensitivity. So immediate hypersensitivities are what we call allergies. They begin within seconds of contact with the allergen and the antigen that causes the allergic reaction. The initial contact with the allergen is asymptomatic, but it sensitizes the person. So when a person develops an allergy, the first time they come in contact, they will not see any of the symptoms that we associate with an allergy, but the body learns that allergen as a pathogen and is going to react in future situations as if it's coming in contact with a pathogenic agent. So each subsequent encounter will cause that immune response. So we release histamine, which is what is involved in the inflammatory response. And this is what also causes the anaphylactic shock, because histamine is driving that inflammatory response. Most of the time we see anaphylactic shock with injected allergens. That's why we associate them with things like bee stings or something that's been ingested because it's hitting the bloodstream. And so the body starts to go into like body-wide response. And what happens in anaphylactic shock is the bronchioles constrict, which makes it very difficult to get oxygen into the lungs. And we also have vasodilation, which means that the blood vessels dilate, allowing more blood to move out of the blood vessels, which decreases our blood volume, as we discussed when we talked about the lymphatic system, about losing that blood volume would be very, very bad. And so this can actually lead to circulatory collapse. This is why anaphylactic shock is so serious and needs immediate intervention, because once that blood volume starts dropping, if you don't intervene immediately, you can actually have heart failure. So the treatment is epinephrine. It's an immediate injection, which immediately starts countering that histamine release. And it is important to follow up. Epinephrine is not a simply like inject and then walk away. It is still a trip to the emergency room, but it is life-saving. Delayed hypersensitivities are slow onset. That means they're going to take several days after contact to see the reaction. And this is because the T cells have to get activated and have to get engaged. And so they're going to take a couple of days for them to fully become engaged and start attacking that allergic allergen, that allergic antigen, sorry. So some examples would be things like getting contact dermatitis from any of the poison plants that we think of, like poison ivy, poison oak, poison sumac. Always remember 3 leaves clustered together is poison ivy, and poison oak also has 3 leaves clustered together. Poison sumac doesn't follow that rule. But in this neck of the woods, you're more likely to come in contact with poison ivy or poison oak. So those are the ones to be on the lookout for. All right. If you would open your glossary, we have just a couple of things left to finish. So if you would turn to page 8, and the third one there is the buboes. Remember, that's the swollen lymph nodes. Then we have immune suppressants, which are medications given to prevent organ rejection after an organ transplant, and their whole purpose is to suppress the immune system. Immunodeficiencies are where T cells and the immune system don't respond properly. HIV is the virus and the disease that it causes, and it attacks the T cells and the immune system, leaving patients open to deadly secondary infections. Autoimmunity is where antibodies and T cells attack the body's own tissues. Immediate hypersensitivity is where the body makes antibodies against benign substances. This is a very quick reaction, and this is what we would call allergies. And then we have slow onset with delayed hypersensitivities, where this is the T cells that are attacking the substance. And an example here would be something like contact dermatitis or poison ivy. And with both immediate and delayed hypersensitivities, we are going to be responding to a benign substance as if it were a pathogen. And so that will finish out our notes and finish out our glossary. So make sure you're studying for that exam.